Bismillah ar-Rahman ar-Rahim, anti-GBM disease, good pastures syndrome, the definition and epidemiology, a linear deposition of immunoglobulin on the basement membrane of alveoli and glomeruli, which damages collagen and in the lungs allow leakage of blood. Anti-GBM antibodies are detectable in blood, alveolar hemorrhage and glomerulonephritis present. The important It is an important differential diagnosis of pulmonary renal syndrome. The annual incidence is 1 case per million. Male to female ratio is 4 to 1. The commonest age is 20 to 30 years. Second peak when women in their late 60s are affected by glomerulonephritis alone. The cause is unknown, often a preceding viral infection. Smokers at greater risk of pulmonary hemorrhage, but not of anti-GBM disease. There is HALA association, which is HALA DR2 association in 60 to 70%. The clinical features include the following: hemoptysis in 80 to 90% and more common in smokers. There is cough, dyspnea, fatigue, and weakness. The examination revealing inspiratory crackles, which are common. The investigations include the following: serum electrolytes, which show impaired renal function and often renal failure, the full blood count, there is iron deficiency anemia, urine dip and microscopy, there is hematuria, there are hematuria, proteinuria, granular and typically red blood cell casts, and occasionally macroscopic hematuria, anti-GBM and autoantibody screen, chest X-ray plus or minus CT, there is diffuse bilateral patchy airspace shadowing in mid and lower zones and may see air bronchogram. The pulmonary function tests. There is restrictive defect with raised diffusion of carbon monoxide if alveolar hemorrhage present. The diagnosis: renal biopsy usually shows diffuse crescentic glomerulonephritis, linear immunoglobulin deposition detected by immunofluorescence or immunoperoxidase. Lung biopsy shows active intra-alveolar hemorrhage with collections of hemosiderin-laden macrophages. There are not specific changes, but may also show linear immunofluorescence staining of immunoglobulin. The differential diagnosis of anti-GBM disease. The differential diagnosis is other pulmonary renal syndromes such as granulomatosis with polyangiitis, Wagner syndrome, and Shark-Strauss syndrome, and macroscopic polyangiitis. The management of Goodbuster syndrome include involvement of the renal team and shared care of the patient. Plasma exchange improve the speed of response to immunosuppression. High dose steroids and cyclophosphamide may need dialysis. And renal function may not improve, and renal transplant is only an option later if anti-GBM antibody levels become low. Recurrence is uncommon once disease is controlled. It usually responds to further immunosuppression, and the residual defects in pulmonary function tests are frequent. The prognosis: rapidly progressive pulmonary hemorrhage and renal failure, usually fatal if not treated. That's all about Goodbuster syndrome, and thank